So guys, it's your Dr. Nas, and I am again here with a new trial. As we have started a series of trials, and especially those trials who have recently come in the update of American College of Cardiology 2022. So as usual, I request you guys before starting this trial that if you want to be with me in the series of trial, I want you to suggest, please at least watch a very first video that how to read a trial, because the terminologies which I use in the reading or in the discussion of the trial or in the trial on the in this video of trial. So I won't be able to explain every aspect or every terminology in this trial. So I want you to please go through once at least within my very first video, in which I actually explained that how to read a trial, and I have explained every terminology of a trial. So this was a CHAP trial which actually came recently a couple of weeks ago. So this was a trial actually which was done on the pregnant females, because this actually told us about the treatment of mild chronic hypertension during pregnancy, because in most of the times as a cardiologist or as a physician, we neglect the mild hypertension in pregnant females, because we think that mild hypertension is because of the physiological changes of the pregnancy, but it is not like that. It is proved by that trial. So this was an open label multi-center randomized controlled trial. Open label means everybody was known that what drug we gonna use with on our patients. So closed or blind double-sided blind trial is usually a trial which is blinded by both sides, like a physician and your patient side. But this was an open label trial, and it was a multi-center and randomized control trial. And objective, what was the objective? As we discussed, that objective was obviously to investigate a strategy of treating mild chronic hypertension during pregnancy with the blood pressure goals of less than 140/90, compared to the strategy of withholding treatment, which we usually do this during pregnancy, which we usually do what? That we hold the treatment in those females who are having 140/90 blood pressure, and we observe and we watch for what? The adverse maternal and perinatal outcomes. So what was the inclusion criteria? The total patients were 24. The total recruited or included patient in this study was 2,408, and the inclusion criteria was pregnant women with a new or non-mild chronic hypertension, like a patient who were having hypertension on their first antenatal care, or they were already having before pregnancy, the singleton fetuses, or at gestational age less than 23 weeks, like the gestational age should be 23 weeks, without high risk comorbidities or complications warranting treatment at a lower BP or contraindication to the first line antihypertensive therapies. Like any contraindication to the antihypertensive therapies, it means you have excluded those females from the study. Or if those patients were taken in this study who were not high risk, like those patients which we usually neglect, which we usually don't treat, because we see that they are the fit and fine, so we don't bother to treat their mild hypertension. Those were the patients who were included in this study. So what was done, that one was the group which was 1,208 patients were given active treatment to BP less than 140/90, like they have to decrease their blood pressure 140/90 with active treatment. The standard or the controlled treatment therapy of the withholding therapy, unless BP over 161. Like as we usually do that, we don't treat our patients in pregnancy with mild hypertension until their blood pressure goes up like 160 or 105. So one was the group in which treatment was held up till their blood pressure goes up, and second was the in which the active treatment continued. As I discussed you that the primary endpoint is very much important for any trial. Why? Because if you have become successful to achieve your primary endpoint, it means your trial is positive. Like if you have it means you have become successful to prove your point. So what they have proved. What was their primary endpoint? The primary endpoint was composite of preeclampsia with severe features and medically indicated preterm births at less than 35 weeks gestation and placental rupture or fetal or neonatal. That was the primary endpoint. Like if this thing was not being done in our group, like in the group in which we actively treated, it means we have become successful to prove that trial, that trial is positive. Like you have to treat your patients in mild hypertension. But if those things, like if those primary endpoints, we will not be succeeded to prove that those primary endpoints were not decreased with mild hypertension, it means your study is not positive. So see that in active treatment groups, there was 30.2% of the patients who were having these primary endpoints, but the control groups were like 37% of the patients, like 7% of the patients were more who were having this primary endpoints, who were having all these complications and all these things. And those were the group, who were in the control group, who were not being treated with the mild hypertension. And what was the secondary endpoint? And secondary endpoint is not something very important, very useful. Why? Because if you are succeeded to achieve the primary endpoint but not the secondary endpoint, but so you can claim that your trial is positive. But in a case like in which you are not able to prove your primary endpoint, but you are succeeded to prove your secondary endpoints, again you cannot claim your trial that your trial is positive. Why? Because you are not able to achieve or prove your primary endpoint, or like you take your primary endpoint. So in this study, they have become successful to prove that their primary endpoint was decreased in their group, which were treated with the mild hypertension. Small for and what was the secondary endpoint? This was the small for gestation, age, birth, or weight below 10 percentile. Like the low weight babies and all these things were included in the secondary endpoint. And what they saw that in actively treated, those patients who were actively treated, they have 11.2% secondary endpoints. Like those were having low birth weight and all these things, but control groups were not having all these things. So now here is the point of conflict, that if you are treating your patients with mild hypertension, it means you are giving benefit to the patients because you have achieved the primary endpoints. And what they did that they kept the things of baby, like infant related things, they kept those things in secondary endpoints. And they knew that if we are treating our patients in mild hypertension, then the birth weight would be low and all these things, because you know that if you are treating your patients actively during pregnancy, then it would directly affect the baby. So the secondary endpoint was higher in actively treated patients. It means that if you are treating your patients with mild hypertension in pregnancy, you are giving benefit to the mother, but you will not give benefit to the baby. So you have to look like that. And what was the conclusion? The target, a BP of less than 140/90 was associated with a better pregnancy outcome. Yes, without increasing risk of small or gestational age birth weight. Why they, now you will ask me that, and they are failed to achieve that secondary endpoint. But the difference between active group and control group is very, very, very low. It is less than 1%. It is 0.8%. That's why it is almost same. You can say that it's almost same, but you cannot say that it is completely safe. You cannot say that. For that thing, that is a limitation of study. You have to do a study in which you have to keep all these secondary points as a primary endpoints. Then you have to do the study and you have to see the results. Before that, you cannot see that because they have put these things in the secondary endpoints. Okay, got it? So that is the important thing, because they have become successful. They became successful to achieve their primary endpoints, and in primary endpoints, the mortality and all these and the adverse events were lesser in the patients who were actively treated for mild hypertension. It means that you can give or you can treat your patients, and it is concluded that if you are treating your patients above 140 by 90 in the pregnancy. So the outcomes of the pregnancy and all these things would be lower, but the risk of gestational age or birth age would not be increased, but still there would be a risk. Okay, still there would be a risk. So I think I have proved my point over here, and inshallah we will do another trial. Here I would suggest you that please share these trials and all and my videos with your peers and all those physicians who are actually treating their patients like this. So probably that thing would be a sadqa jariya, and that would, and my message, my hard working and my all these things would be beneficial for our population. So subscribe my channel, press the bell button for the newer updates and the newer trials. Take care. Allah Hafiz. It's your Dr. Nays. Take care.